It's my pleasure to be here and to describe to you a new business that we're creating at CVS Health. And before I do so, I just want to address a few points and maybe get a couple of slides up. The first is on innovation. And so innovation to me is simply something that's new that adds value. And what you're going to hear from us is an innovative way of thinking about delivering health services in the kidney disease space today. We not only applaud, but fully support the activities that Sandeep spoke about earlier around KidneyX. Any future thinking models of kidney care, kidney development, innovation in the space. If we could avoid any future dialysis, then we would be extremely supportive of that. So what I'd like to describe to you today is how we're thinking about innovation today, because we recognize there's a need today to improve the outcomes for patients and to improve quality of life. So I'm going to start with just a little background on CVS. And the reason I'd like to do that is because I'm not sure how many opportunities CVS Health has presented at kidney-related meetings or patient-related meetings such as this. So just a little bit of a background. Before I joined CVS a year ago, I always thought CVS was a pharmacy with a retail store in the front. That was the limit of my education around CVS. That's grown over the last 12 months. So in 1963, actually, CVS opened their first store in Lowell, Massachusetts. This was a retail store. Pharmacy became part of CVS in 1967. And in case you're wondering, CVS stands for Consumer Value Stores. And again, that's something that I also learned over the last 12 months. Over the course of the next 30 years or so, CVS has changed considerably from a retail store and a pharmacy store. And some of those changes that have been instrumental included the acquisition of MinuteClinic in 2006, a PBM called Caremark in 2007, and we have over 10 million members involved in Caremark today. In 2014, the company made a very important decision, changed its name from CVS to CVS Health, and said that we're no longer selling tobacco. And that meant $3 billion, that's right, $3 billion in annual revenue that the company was walking away from. And then in 2017, we announced our planned acquisition of Aetna. And our CEO recently has stated publicly that things are going well, and we anticipate the close of that at some point in the near future. Just a little bit more about CVS. So we have 11,000 clinics around the country. If one excludes the Pacific Northwest, where we don't have too many CVS stores, we are within 3 miles of about 90% of the U.S. population. If you look at the Minute Clinics, we have about 1,100 Minute Clinics. And again, excluding the Pacific Northwest, they're within 5 miles of about 90% of the U.S. population. So 5 million people walk through the doors of a CVS store every day. And the reason I'm telling you all that is I just want to give you an idea of the scale that CVS can bring to the table when we start thinking about changing or disrupting the care model for kidney care today. That's really the only reason. So our goal is to make kidney care more accessible, closer to home, and to think about kidney care more holistically, outside of just a model of dialysis. Even though we recognize that's important, but we want to think about it more holistically, more upstream, looking at what's important for patients before and after they need renal replacement therapy. So, in addition to that scale of sort of a footprint across the country, these are some of the services that CVS has today that we feel are, many of which are essential for us to be successful. So where possible, we're trying to use what services exist within CVS today to help us be successful as a kidney care business. So I'll start on the right. So you know about the CVS pharmacy. The CVS specialty is here, and I just want to say that we've got a long history of working with patients within the chronic disease space, not the kidney care space, but other patients with other chronic diseases such as ulcerative colitis, multiple sclerosis, etc. We also have a dedicated team, a technology team that works on patient engagement and customer engagement, a very strong analytics group that will help us with our identification of people with kidney disease, and also help us risk stratify so that the intervention is directed at the right patients at the right time. We've made some very big investments in telehealth. We are transforming how we think of minute clinics so that they offer more of a chronic disease service connected to providers and connected to patients through technology. We have a business called Accordant Care, and Accordant Care is a virtual nurse coordination company. So they work with patients who have chronic diseases that are high cost and help those patients navigate through the system. And these are nurses that are specially trained within that disease state. So we're currently working with Accordant to develop a chronic kidney disease model for patients who have kidney disease before the onset of dialysis, so stage 3 and stage 4 kidney disease. And so this is, the reason why a company like CVS is interested in kidney disease perhaps shouldn't come as too much of a surprise, right? So we've heard $34 billion today, and it's actually, I think, $37 billion this year that's being spent on the care of dialysis patients. If one looks at the total bucket of kidney disease, it's over $100 billion that somehow is being spent in caring for patients who have some form of kidney disease. $100 billion. You know that about 500,000 people in this country are on dialysis, and about 700,000 have kidney failure. So there's unmet needs with regards to cost to our system. And this isn't just about saving costs, but it's also thinking about maybe how we could spend that money in a different way. There's also obviously unmet clinical needs, which I'm sure many of you here today recognize personally. Mortality rates are high, 10 times higher than matched controls within the CMS population. On average, a dialysis patient is hospitalized 11 days per year. Now, I can't imagine having to go to hospital. Family members have. I've been in hospital for family members, and it's impactful on the whole family. So 11 days in hospital, on average 2 hospitalizations per year. And the 30-day readmission rate is double compared to matched controls within CMS. So this just isn't a cost issue. This really is an impactful disease, an impactful problem on patients and their family members. Here are some of the problems that are associated with this. So 96% of people who have kidney damage don't know they have chronic kidney disease. About half of patients who have reduced kidney function are not aware of their kidney disease. And about a third of new kidney failure patients, new patients who need dialysis, have received no or little kidney care before they start dialysis. So the innovation in this area is not necessarily related to creating a new technology. This is really, and I was saying earlier to some people I was discussing, this isn't rocket science. We know what the problems are. We also know what interventions work, but they're not being delivered. There's a lot of focus on dialysis, and there's very little focus on moving upstream. So we also know that there are options, but they seem to be difficult. So access to kidney transplantation is clearly inadequate. So preemptive transplantation, as an example, should be commonplace. In fact, it's rare. We think technology can be improved. It's not just technology that delivers dialysis, but also technology that improves patient engagement and education. And the other piece that seems difficult, but again, it shouldn't be, is around home dialysis. So if you ask nephrologists, and I think most of you probably know this, if you ask nephrologists if you had kidney failure, what type of dialysis would you want? 90% plus say, I want home dialysis. Only 12% of patients today are being dialyzed at home. And I need to be very careful here on the in-center treatment model, but I think it's wrong. 4 hours or less in a chair 3 times per week is very disruptive for patients and their families. And that 2-day gap between treatments, we know that creates problems. But that's what we have today. And we spend $37 billion on that. So I'm just going to lay out a new model that we are developing, and we've made quite a bit of progress on. And that new model supports patients throughout the progression of their kidney disease. And on the far left, we are working on systems to help with early identification and multidisciplinary care for patients who are identified with different stages of chronic kidney disease. So we do believe that there are patients who need more education, and that education may be virtual, it may be scalable at a virtual level, and it does not have to be extensive very early on. We also know that if you look at the risk of an individual patient, some patients progress a lot faster than others. We don't always know why. There are markers for why some patients progress faster than others. They're going to need a deeper level of intervention. And that intervention is going to go beyond just being virtual and also needs to be face-to-face. And it needs to be timely. All this means that patients also need to understand their treatment options. They need to be engaged. We need to engage with patients. Again, this isn't, all these interventions, I know Dr. Starr earlier said there's been very little in this space that's been shown to slow progression of kidney disease. That is true. I think ACE inhibitors and ARBs have made a difference. But there are other things that patients can do to lower blood pressure, to look after your health, to have a better diet, to feel better, and we can do a much better job at supporting patients through that care continuum. And then for those patients that unfortunately do need dialysis, that aren't able to get a transplant before they start on dialysis, why should that start in hospital? Why do you have to be hospitalized to start dialysis? Why should you be surprised? Our numbers for fistulas that are mature for patients that need dialysis are not acceptable. 50% of patients starting dialysis in hospital is not acceptable. So we really believe there are ways that we can improve that model of care. Again, some of it is through identification, some of it is through targeted management, and a lot of it is through better patient engagement. And then finally, we do believe home dialysis should be more than 12%, both PD and home hemodialysis. We need to figure out a system, not just technology that we're working on, but also a system in how to ensure patients understand the options for their care and work with you so that education is appropriate for patients to better understand your options and increase access to home dialysis. No patient should have to wait 3 months to get trained on PD. And when you're home on PD or you're home on home hemodialysis, your engagement with your healthcare provider should be easy. It should be something that you could do every day if you want to. and that data transfer should be easily accessible to your provider. So I'm actually going to end there because I suspect there's going to be lots of questions.